Dr. Hendifar, and Dr. Del Rivero up for a question and answer session. And if you have questions, again, write them down on the note cards that's provided at your table, if you don't mind, and put your hand up, and someone will, one of the volunteers will pick them up. Okay. So I saved some of the questions from earlier, because now we have a medical oncologist, Dr. Hendifar, an endocrinologist, Dr. Yu, and someone who's both a medical oncologist and endocrinologist to cover many of these questions. So, and we have about 45 minutes. So there's a lot of interesting questions here. Let's start with the questions about the somatostatin analog. And actually, I don't know, I think Dr. Yu, you were on some of these trials, right? So, Dr. Yu, does lanreotide, octreotide have a lifespan? And if effective, does it only work for a certain time period?
Okay. Octreotide and lanreotide, they are very, very similar medications. We basically view them as interchangeable. So, for example, if insurance asks you to change from octreotide to lanreotide, it is not under war. But some people do respond to one of them a little better than to the other. In terms of the duration of use, so this is a little bit controversial, but I probably am in the minority group in that. So most people with any known tumor burden should be on one of them, either octreotide or lanreotide. But if their tumor begin to progress, some doctors, I have some of my UCLA oncology colleagues would stop the octreotide or lanreotide and thinking it is no longer working, right? But I actually view this differently. I think the patient should continue this and adding a new treatment other than switching to a new treatment. So I think that this patient should be treated long term, even though their tumor progress. The tumor progress does not mean that the medication not working. It just means the tumor now is a little different.
Okay, thank you. Dr. Hendifar, do you have anything to add to that?
No, that was a great summary.
Okay, thank you. And actually, Dr. Hendifar, can octreotide cause long-term hip or muscle pain that you're aware of?
Yeah, I think it hurts when the needle goes in, right? It looks, I could never do it. I don't know how. I'm so scared of needles. But sometimes, I've seen patients who get reactions to the medications too. So they'll get what's like a granuloma, like a bump. And then you'll have to switch. Even when you switch sides, the bumps sometimes last more than a couple of months. So it gets very hard. But we do have a new formulation. That might not cause these problems.
Great.
So something to look forward to in the future.
Actually, that was my question for Dr. Del Rivero. Is there an oral octreotide pill coming out?
Yeah, there is an oral octreotide coming up, and that's the one, the paltusotine, the one that there has been some studies about. The name of the medication is called paltusotine, which is an oral form of somatostatin agonist. Currently, the studies is for symptoms related to carcinoid syndrome, mainly diarrhea and flushing, and I will talk briefly about it on my presentation later today. But the results of the current phase 1, it was reported in one of the conferences this year. It really demonstrates a benefit of using paltusotine for flushing and diarrhea. If you ask the question what happened with my tumor, because that's sometimes the question that I get, whether the oral medication can also stabilize the tumor, as we have seen with the injections, we still don't know the answer to that. Currently, the studies is mainly for the symptoms related to carcinoid syndrome.
Great, thank you. Dr. Yu, we'll go back to you. There's several questions for you. If NET patients have a propensity for diabetes, what can they do now to prevent it or mitigate it?
So just eat healthy and exercise as much as you can, and follow, and also be mindful about this sugar issue yourself. You can bring it up to your primary care doctor, to your oncologist, to say that I heard I'm at higher risk of having diabetes or high blood sugar. Can you refer me to an endocrinologist if my sugar is levels are already high?
Thank you so much. Dr. Hendifar, would a NET oncologist need to check serotonin levels if you already know you have carcinoid syndrome? And what's next if the serotonin is extremely high, over 1,200, and they're already on lanreotide?
How high?
Over 1,200.
So these are very, very good questions. The best test, I think, is probably most important that even if you don't have flushing and diarrhea, and you have a midgut tumor, and maybe even other tumors, you should definitely do a 24-hour urine for 5-HIAA, or 5-hydroxyanolytic acid. So breakdown product of serotonin. It's a good test to know if you have carcinoid syndrome, because surprisingly many people will have it without flushing or diarrhea, which is weird. When you diagnose with carcinoid syndrome, you can use the 24-hour urine test to measure how the patient is doing. It's like an indirect measurement. But my only issue is that it's hard for the patient to do sometimes because they have to carry around the canister for a day. It's not a very convenient test. And I think usually we use the imaging more, but it can add, depending on the situation, it can add some important information. So, if you guys don't mind doing it, I think once a year is a very reasonable thing to do. Yeah.
Dr. Hendifar, I actually have a follow-up question related to the heart. What's the relationship between heart issues and neuroendocrine tumors? Can the heart surgery have an impact on neuroendocrine tumors?
No, that's a great question. So, if you have the carcinoid syndrome, which is the neuroendocrine tumor that makes serotonin, there's a small chance that it'll damage your heart valves. And the heart valves are specifically on the right side, and they're tricuspid pulmonic. That's the easy, straightforward way to understand it. What was that second part of it? Oh, can heart surgery help? Yes.
Or can it have an impact on neuroendocrine?
Yeah, if you can identify the valve issues early, and you can't do it based on how you feel. People feel perfectly fine for a very long time. You need to do an echocardiogram, and you need to do a blood test, beta natriuretic peptide. You should do those probably yearly if your tumor is making serotonin. And the only way to know that is if you do the 24-hour urine. So this is the thing, right? Because you might not have flushing or diarrhea. So if you have that, you should do those tests yearly, especially now where we have such a safe, easy procedure to replace the valves. There's no age limit for that, and anyone can do it. And I think we're going to be much more eager to replace valves earlier on. Used to be, oh, you have a little bit of damage, we'll hang it on, we'll send it to the cardiologist, and the cardiologist says, well, you have a big surgery, and you have a little bit of damage, and the patient feels fine. Let's just watch it. But I think now with these new procedures that we have, we're going to be less inclined to do that because the negatives of a big open heart surgery are not there as much.
Thank you. You have something to add, Dr. Del Rivero?
Yeah, I would like to add on the prior question about whether the numbers of 5-hydroxydolacetic acid, what that means, like if 500 is better than 1,000, or what are the symptoms related with the number of, or what we see in the results of the urine 5-HIAA. But another thing that I would like to mention is, like, I agree with Dr. Hendifar, sometimes doing a 24-hour urine collection is harder for patients. But that said, there is a blood 5-HIAA, which I think is easier for patients. That said, it's not something that is widely available. Mayo Clinic is one of the institutions that had that availability of doing the blood tests. Some of the other lab tests like Quest and others may not have that availability, but I know they're working on getting the blood 5-HIAA available in different centers. I think it's easier. The studies that has been done at Mayo Clinic and also in Europe, because Europe also has used the blood 5-HIAA, is the same. So I think there is so much that availability is an issue, so hopefully something that will be available in many centers. But I agree with Dr. Hendifar. I don't think there is really a straight relationship between sometimes how much between patients, the number of 5-HIAA with sometimes the symptoms related to that. There may be patients that have very elevated 5-HIAA, but as Dr. Hendifar said, they may not necessarily have any symptoms, and there are patients that have maybe much lower 5-HIAA than other patients, and they have severe symptoms. And that also goes with the so-called carcinoid crisis as well. I don't think there is also a number that tells me like, well, this is the number that somebody needs to have in order to be a higher risk of carcinoid crisis. There is also no relationship. But that said, we need to be aware of the symptoms related to a specific patient and how we're able to mitigate some of those symptoms, because whenever we have a patient that have carcinoid syndrome, it's not just treating the tumor, but also treating as well the symptoms related to carcinoid syndrome, which sometimes we need to have an extra measurement in order to control the symptoms.
You're really speaking to treating the whole person and individualizing the care. Yeah, thank you. Dr. Yu, how does menopause affect NETs, and can people take estrogen if they're in menopause?
Yes, I'm not aware of any bad effect about, say, you have a neuroendocrine tumor, now you are in menopause, your tumor will get worse. There's no evidence of that. And on the flip side of that, if you have a menopausal symptom, they want to take HRT, and that's totally fine.
Thank you. Dr. Del Rivero, I know you see all types of NETs. It seems that lung NETs is not as common. Is that right? And if so, why?
I think that sometimes how we classify neuroendocrine tumors is usually lung neuroendocrine tumors, and we group the gastroenteropancreatic neuroendocrine tumors. But the reality is that lung neuroendocrine tumors is not as rare as someone may think. I think in terms of the number of lung neuroendocrine tumors or neuroendocrine neoplasms, if we start counting the other neuroendocrine carcinomas and the other more aggressive type of lung neuroendocrine tumors, is not necessarily as rare. It may be even more common than the gastroenteropancreatic neuroendocrine tumors. So in terms of lung neuroendocrine tumors, and I believe Dr. Chauhan is going to give a talk about the classification of all lung neuroendocrine tumors or neuroendocrine neoplasm. We have the more well-differentiated, the slow-growing, but then we have the other counterpart of the lung neuroendocrine neoplasm, which are the more aggressive. So we take that into consideration. It's actually more common than the gastroenteropancreatic neuroendocrine tumors. So the gastroenteropancreatic neuroendocrine tumors, we usually group them, the two of them. More common is the small bowel compared to the pancreas. But that said, yes, I think the classification is a little bit more complex. And we know that neuroendocrine tumors can be anywhere in the body. But yes, in terms of the more well-differentiated, maybe less common than the other one, but in terms of the whole lung, it's just a different classification. Yeah.
Thank you, Dr. Del Rivero. Dr. Hendifar, I know you mentioned DLL3. What do you think of DLL3 in treatment of NETs, especially in lung NETs?
I think for the tumors, so it's right now approved for lung carcinomas and being studied in carcinomas from other GI areas as well as high-grade NETs. So I think it's very promising in patients with higher grade neuroendocrine tumors. Now the low-grade tumors, I think we don't know yet, and it'll be a while before we find out, because they're first going to study those with higher grade. But there are a lot of success stories out there, so it's a promising approach.
Thank you. Okay. Dr. Del Rivero, any evidence belzutifan can have benefits for PNET patients without VHL? And could it be used as a first-line treatment?
Okay. That's a very good question. So belzutifan, as Dr. Hendifar really nicely explained earlier, is approved for VHL-related pancreas, neuroendocrine tumors, CNS hemangioblastoma, as well as kidney cancer, because part of the clinical presentation of VHL. Now, what we know is that approximately 25 to 30% of pancreas neuroendocrine tumors not associated with VHL may have somatic VHL mutation, which is very important to identify, but also make the difference between somatic, which is mutation which is only in the tumor, and germline, which is everywhere in the body. And the germline mutation has the risk to pass to your kids, but not the somatic, it's only in the tumor. That said, Merck is currently doing a study of besultifan in patients with pancreas neuroendocrine tumors, and they also wanted to understand whether the somatic mutation may have an association with that. We still don't know the results of that study. It's ongoing. The study still is opened, not for accrual, because Merck is trying to analyze the data. So hopefully in the next few months we have more information whether VHL in the tumor, not germline, may benefit from besultifan, but as of now we don't know.
Thank you for that. Dr. Yu, can NETs affect this one is for you. Can NETs affect motility or the treatments?
You mean the GI motility?
I think so.
Yeah, and it is a little complicated. Most people don't have a GI motility issue if they have a small tumor burden. Serotonin actually can increase GI transit, meaning that make the motility faster, so they have even poor absorption.
Okay, thank you. Dr. Hendifar, I know you mentioned the cabinet study. Someone's asking, didn't they pause the cabinet study and put everyone on it, or anyone on it, because of good results?
Yeah, that's right. They stopped it early because it was working so well. Yeah, and there was a crossover on that study. So everyone was able to get the medication. So that's a great when they can finish something early because it's working so well. Yeah.
Yeah, thank you for clarifying. And Dr. Yu, back to you. If a patient had pancreatic NET surgery and the A1C went up to 6.3, so they're pre-diabetic, should they get treatment sooner?
You don't have to, but you certainly can. So you want to, if your tumor burden is relatively small, and there's no reason you cannot start a metformin or some similar medication. But if you really don't want to use a medication, you don't want to minimize the number of medication, you can wait and monitor the A1C maybe every 6 months or so.
Okay, thank you. Dr. Del Rivero, is it normal or typical for the liver to swell enough to be felt through the skin on the course of 6 months so far of lanreotide injections?
So that's a
Or you can defer to your colleagues,
yeah,
Dr. Hendifar, Dr. Yu.
It's kind of like, I don't think I have
No.
Yeah, I don't think I've seen that.
It's
No.
not a side effect. I mean, maybe you've lost some weight.
Yeah.
I mean, then maybe you're just feeling, or maybe you're just feeling it and you're just noticing it.
Can
But there's no liver swelling.
If your doctor confirms the liver is actually getting bigger, that's an important sign you don't want to miss. But it could implicate that your tumor is getting bigger.
And there's a follow-up question. Will PRT stop the swelling,
What swelling?
the swelling of the liver?
Well, I think, one thing is that we need to kind of like understand what swelling mean. Because when a patient says swelling, meaning that they have the feeling that something is getting bigger. But as mentioned, could that be a sign that maybe the tumors are getting bigger? I mean, we don't know whether it's because the patient lost weight, because, we know sometimes with the lanreotide can cause diarrhea as well, and maybe that lost, muscle mass, and then you feel it a little bit more. I mean, that could be another reason. But that said, if you feel that things are not the same or getting, unusual, absolutely, that will be something that needs to be discussed with your treating physician, because maybe more tests needs to be done. But those are the things that I can think of. Yeah.
Okay. Thank you. Okay, so this is a question about sequencing. So this person's finishing a PRT, And what comes next in terms of care? What are typical options? What can be used? And what determines a choice? So Dr. Hendifar, let's start with you.
Usually in patients who are getting PRRT, they're on somatostatin analogs concurrently. So they'll be continuing that treatment and getting scans every few months. And I would say if there's signs that the tumors are growing, the one thing you could do is continue to watch them if the pace is quite slow. And you have several other treatment options depending on, the organ where it started. So there's lots of great treatment options and different things that you can possibly do. It's always hard to do kind of like a scenario where you're just asking, what are you going to do next? I think the thing with neuroendocrine tumors that are different than most cancers is that everyone's is a little bit different. So when you look at like breast cancer or colon cancer or lung cancer, the experiences are much more aligned with one another, and the sequencing is much more straightforward because it's basically best practices to do things a certain way. With neuroendocrine tumors, it's a little bit different. Generally speaking, if you have a midgut tumor, you would do somatostatin analog, you would do Lutathera next. After that, maybe depending on who you see, might be cabozantinib. And if you have a pancreatic neuroendocrine tumor, right now, after somatostatin analog for a low-grade tumor, if you had a high-grade tumor, you probably wouldn't start with somatostatin analog. And for pancreatic NETs, we don't know if Captem or Lutathera is better. So right now, there's a nice study that we're doing when we're randomizing patients. But otherwise, it's kind of like a coin flip.
Dr. Del Rivero, do you have anything to add?
I didn't mention everolimus.
No, I completely agree with Dr. Hendifar. I mentioned this earlier as well, that in neuroendocrine tumors, it's not like one size fits all. We personalize the therapy based on different characteristics, locations, what is pancreatic or non-pancreatic, whether they are functional or non-functional, meaning that if they has symptoms related to the hormone excess or not, whether they express the somatostatin receptor or not, whether they only have disease in the liver or disease everywhere, whether there is a slow growing or rapidly growing. I think those are the different characteristics that we need to understand in a patient that is diagnosed with neuroendocrine tumor, because based on that, we tailor the treatment options. And I can understand that sometimes that can be frustrated for a patient, because sometimes you may have a difference in opinion. But at the same time, I think it's important to ask those questions to your doctor and why you recommend an X treatment or Y treatment, so that way whatever decision you make, it makes the most sense. But yes, I think that can be one discussion that you need to have with your doctor. But that said, one take home point is that we have now treatment options. In the past, maybe 20, 30 years ago, we didn't have that many treatment options, but now we have treatment options that we could certainly consider between Lutathera and now the ongoing clinical trials with the alpha. We discussed earlier the alpha versus the beta. We have the cabozantinib. We have treatment options, many treatment options that we just need to talk to your doctor what makes the most sense and at what time. Yeah.
And also, what about surgery or any liver-directed therapy? Would you also go back to those things after PRT? Dr. Hendifar?
Yes, I heard surgery, absolutely. What was the other thing you said?
Liver-directed therapies?
Liver-directed therapy, those are all options, yeah.
Okay, thank you.
Absolutely.
And that can also be done even in between therapies. That's another thing about neuroendocrine tumors. We have all these options, and then you can always consider surgery. You can always consider different type of liver-directed therapies, and that can also be in between therapies as well. And those are the things that needs to be discussed, with your doctor as well.
Yeah, I know. Unfortunately, we don't have our liver-directed therapy speaker here today, but again, we have some podcast episodes on it. That were released last month and will be released this month. Dr. Yu, how common is joint pain as a side effect of lanreotide? This person said rheumatoid arthritis was ruled out already, but why would lanreotide cause joint pain?
It's been known, the side effect to somatostatin receptor analogs are very, very diverse. Most common are fatigue, maybe even worse than the diarrhea, high blood sugar. But some people do have a joint problem. So if the problem is really, really bad, you can either consider taking some painkiller to see if the pain is tolerable, or you may have to stop taking the medication.
Thank you. Dr. Hendifar, if one has extensive removal of a portion of the small intestines, colon, and ileocecal valve, but no flushing, how do you decide whether the diarrhea is caused by short bowel or carcinoid syndrome?
Yeah, that's a very good question.
Sorry.
Yeah, so it would, this is working?
Try the other mic.
Hello?
Yes.
Maybe that was dying, the mic dead.
Okay.
Usually the first thing we do is get a good history of was there diarrhea before surgery and flushing. And if there was no diarrhea then, the suspicion is a little bit lower. But what you can do afterwards is you can do a 24-hour urine test. We can do the plasma test. Although from the plasma test I ordered from, I always felt it was a little bit less reliable than the urine test. That's why we've kind of deferred to that. Yeah, with the 24-hour urine test, you should be able to know if they're making serotonin. But I will have to say that having diarrhea after what sounds like a pretty extensive intestinal surgery is very common, very challenging to deal with. Definitely should seek out the help of a dietitian. Talk to the surgeons. Don't let them off the hook. They're here. We got scared. There's ways that you can bulk the stool to slow it down. There are different things you can intervene on. A lot of times, sandostatin can help with diarrhea. So if we're not using it for the carcinoid syndrome, and we're not using it for tumor control, you can sometimes use it for a twofer. You can also control the diarrhea. What other issues happen? Weight loss can happen, which is tough when you have weight loss because of, sometimes people call it short gut, and it's a tough situation to deal with. You can get vitamin deficiencies when you have surgery, so you have to make sure your B12 is replete. I would check iron. Sometimes if you're doing somatostatin analog therapy and you have short gut, you might get malabsorption. Malabsorption means you might have weight loss from fat malabsorption, and you need some medications, enzymes, pancreatic enzymes for that. It can also mean that you're low in vitamins D, E, A, and K. And what's really nuts, in medical school, they always teach you, vitamin A deficiency gives you blindness, and there's a lot of vitamin A in polar bear liver, right? Something like this. And you're like, whatever, but it sticks in your mind. And then, 40 years later, I meet this person, very lovely woman, and she's like, yeah, I'm starting to not be able to see at night. I'm like, what? So thank God the dietitian was checking her vitamin levels, and sure enough, she had no vitamin A at all. Wow. Yeah, and hers was a combination of exocrine pancreatic insufficiency and SIBO. And she had severe, SIBO, small intestinal bacterial overgrowth. And so she had a lot of issues, and nutritional issues that you wouldn't really think about or expect.
Wow, thank you for that. Very enlightening. Dr. Del Rivero, it seems most NET cancer patients have diarrhea, and also treatments like lanreotide cause diarrhea. What might cause chronic constipation in a NET patient, and what would you recommend as a next step?
Chronic constipation. Okay. Now I'm going to put my pheo hat here. Because so in pheochromocytoma, certainly because of the excess of hormone can cause severe constipation. That's completely different than the other cancers, the GI or pancreas neuroendocrine tumors. Just because this excess of hormones, catecholamines can definitely slow down the gut motility, and sometimes it can cause severe issues with constipation. But that's a different and more rare type of neuroendocrine tumors, but I think it's important to also mention about it. In terms of other neuroendocrine tumors, pancreas neuroendocrine tumors, I mean, sometimes, depending on the non-functional tumors, sometimes you may have a decreased motility. That said, I mean, as we get older, as we know, our intestines doesn't work as good as somebody who's younger, so you have to also keep that in mind, and that has nothing to do with the neuroendocrine tumor per se. We discussed about the different type of diarrhea as well. One could be related because of the worsening symptoms related to carcinoid syndrome, and that's, as Dr. Hendifar said, it's important to measure the hormones at that moment just to kind of like understand more about the cause of diarrhea. Lanreotide can cause diarrhea, or patients that had undergone surgery that can also cause diarrhea. But in terms of the constipation, that's usually more on the non-functional side of the neuroendocrine tumors, because the other pancreas neuroendocrine tumors can cause some type of diarrhea just because of the hormones associated in the pancreas. But other than that, it's kind of like we also need to understand, because like I say, getting older can also cause decreased motility as well. Also, telotristat can also, if somebody is taking telotristat, that can also cause constipation in patients. And telotristat is the medication that blocks the rate-limited enzyme for the production of serotonin, so tryptophan to serotonin, so that can also cause severe constipation in some patients.
Great, thank you. Dr. Hendifar?
Yeah, just want to add to that. So, there is a rare hormone, PYY. Yeah, it causes constipation. I've met a lot of patients who have side effects from their tumors that other patients don't have, and that seem quite unique to their own experience, and I wouldn't discount them. A lot of things we don't know. Like there are things we check for what we know, right? We don't check for what we don't know about. So you could have a rare hormone, you could have a rare thing, it could affect your body differently than somebody else, and definitely cause all sorts of symptoms. But I would say some of the general principles we have is, if the symptom you have gets better when the tumor is out, then that gives you a sign that they're connected. So that's what I would think about. And if your symptoms are getting worse as the tumor is getting worse, right? So if you can connect them to the tempo of your cancer, then that would means that it's quite related. Yeah.
Oh, thank you for that insight. Dr. Yu, as a NET patient, does having a family history of diabetes, meaning mother or father, multiply one's risk of diabetes?
Yes. So family history of diabetes certainly raises the risk than anyone with or without a neuroendocrine tumor to have a diabetes.
Okay. Is there a separate risk of regular diabetes and a separate risk of treatment-related hyperglycemia?
Yes and no. So yes, partly that. So you have a general, say if you are overweight, have a family history of diabetes, this just increases your chance of having diabetes. But on the other hand, for the treatment-related diabetes, the exact extent of treatment, what specific treatment you have, also matter. For example, if you have a pancreatic tail neuroendocrine tumor, your doctor did a distal pancreatectomy, and 80% of your pancreas are preserved, and you otherwise do not have any other neuroendocrine tumor, the chance you will have a sugar problem is very, very low. On the other hand, if you have a large pancreatic neuroendocrine tumor, the doctor removed 80% of your pancreas, then the risk of having high sugar is much, much higher.
Thank you. Dr. Del Rivero, sometimes patients are concerned after taking Captem or PRT and they're stopped and they're no longer on the treatment. Can it still work in shrinking the tumors after they've stopped? And if so, why?
Right. So yes, and maybe Dr. Hendifar can add as well on that. So that's a common question that I have, for example, with CAP10. Usually what the recommendations are is that we give CAP10 for anywhere from 6 to 12 months. And one of the reasons is because the cumulative toxicity associated with this type of chemotherapies. And sometimes, the patient may ask, do I still have some activity after the stop, and for how long? And it's kind of like a very difficult question to answer. But one thing is that what we think about some of these drugs is that sometimes these drugs goes at the level of the cells, inside the cells and the nucleus of the cell of the cancer cells, and sometimes it can stay there and float around for a while. And because of that, sometimes we feel like these can have an effect even after the stop, which is different than the half-life. The half-life is a drug, how much you can measure in the blood, and that's the reason why whenever we do treatment studies, the phase 1 of the study is to understand what is the time of the drug circulating in your body, and that's kind of like one of the questions, and that's what we call the pharmacokinetics or PKs, and that's why any patient in a phase 1 studies, we draw a lot of blood to understand that. But sometimes from that to the understanding on how the treatment goes into the cancer cells and it affects into the nuclear and the DNA, sometimes it may still be floating around for a little bit longer. So it's kind of like it's still unclear for how long and when, and that happened the same with immunotherapy as well. With immunotherapy, it's after we stop, so sometimes it can still be working for a while, but that says more of the research questions to understand exactly what level and when and for how long is still unclear. I don't know.
Do you have anything else to add, Dr. Hendifar?
Yeah, imaging is not that great. I'm glad Dr. Auerbach is not here. Yeah, imaging is just not, it's not perfect. So what you see on pictures is not always exactly what's happening. So you have to keep that in mind when you get scans. And that's why, you know, a tumor today, you know, sometimes the way I explain to people is like, your tumor might be like a dead bug. It's dead, but it's still there. You can still see the exoskeleton. And that can be like what you're seeing on the scan, for example, sometimes. But really, the bottom line is it's just not that. They're not 100% accurate. So it's true that the medications can continue to work after you stop them, even though that doesn't make a lot of sense.
Right, I know.
And a follow-up question, Dr. Del Rivero. If you start a medication, how long do you, say everolimus, but if you start a medication, how long do you decide to keep the person on it? Do they stay on it indefinitely, or how do you decide when to stop or switch medications, treatments?
Yes, I mean, it also depends a lot on the side effects. Like, for example, for CAP10, which we talked the combination of capecitabine and temozolomide, like I mentioned earlier, usually the recommendations is anywhere from 6 to 12 months, just because of the cumulative toxicity. The longer you're on the medication, sometimes it accumulates side effects as well. With the vidofludimus, for example, the same with the tyrosine kinase inhibitors, as Dr. Hendifar, like cabozantinib, that's one of them. So we usually continue as long as we see that the medication is working in the patient's tumor, or if we feel that there is significant side effects that the patient is unable to tolerate. So at that moment, we just discontinue the therapy. But we usually continue these medications until we see a benefit to that. Sometimes, they may, after some time, after a year, so patients may say, well, I want to really stop it for a couple of months because, I want to go to a cruise, I want to do some activities because sometimes the medication make them sick. I think it's reasonable to do that. It's reasonable to hold it and then after that restart. So I think it's reasonable to do that. I don't know what you think, Dr. Hendifar.
No, I agree. Yeah.
And Dr. Hendifar, if someone, like say CAP10 worked for someone, can you go back to the same treatment that worked for someone later on?
Yeah, I mean, I think it's hard to say outside of the, your doctor knows you the best and probably knows what's best for you, but I've re-challenged with CAP10, especially, I usually give it for a year, the capecitabine and temodar. Many times I continue the capecitabine past that year. And if down the road you're in a bind and you need to use the temodar again, for sure, we've done it, and successfully. Mm-hmm. But we try not to, the first principle of medicine is don't cause harm. So if we have a medicine that if we think we give too much of it could be a problem, we try not to do it. Although I gotta admit, I've never had a case of a patient who developed bone marrow cancer from temodar.
Oh, wow, thanks. Dr. Yu, how often should someone with NET see an endocrinologist?
Well, yeah. So depending on the treatment pattern in your local community. So some neuroendocrine tumors are primarily endocrine. For example, insulinoma in the pancreas is primarily seen by endocrinologists. Well, for the small bowel carcinoid are usually seen by GI oncologist or oncologist. But if you have any endocrine concern, for example, your doctor said, oh, your tumor may produce a hormone, or you have, say, high blood sugar or treatment-related thyroid problem, then you should definitely see an endocrinologist. But in some communities, the endocrinologist might be the local expert for your even small bowel carcinoid. But in most developed communities, where there are a lot of doctors, usually the GI doctor sees those tumors.
Thank you. Dr. Del Rivero? So she's double board certified.
I know. I sometimes like to put my endocrine hat. I do feel I completely agree. What is mentioned about that. Some of these tumors may produce hormones where an endocrine care is very important, and it's usually something that it could be a long term. But as very nicely discussed earlier, sometimes we need to understand if the tumor is producing a hormone and what hormone is producing, so that way we can provide the adequate treatment. But also some of the therapies may produce endocrine side effects, and that's kind of like something that we need to understand, and also that requires a long-term care by the endocrinologist. Two other aspects I would like to mention is about patients with more rare endocrine tumors, and those are the pheochromocytomas and paragangliomas, for which these patients has very elevated blood pressure. So these patients do require sometimes a long-term follow-up with our endocrinologist to help manage the blood pressure. The other aspect I would like to mention as well, because that can happen in lung neuroendocrine tumors, sometimes in pancreas neuroendocrine tumors more rarely. Sometimes we see it on another very rare type of thyroid cancer that is also neuroendocrine thyroid cancer, which is called medullary thyroid cancer. Sometimes it can produce excess of cortisol. And this excess of cortisol causes a syndrome called Cushing's syndrome. That needs to be managed by an endocrinologist, and that needs to be very aggressively managed by an endocrinologist, because that can certainly happen. Like I said, in lung neuroendocrine, pancreas more rarely, medullary thyroid cancer, but we see that as a presentation.
Yeah, there's certainly some situations. We'll end with this last question, Dr. Del Rivero, since you have the mic. We'll start with you, and we'll go down. What advances going on right now or in the future are you most excited about in neuroendocrine cancer?
Okay. Well, that's a good question. I think there is, Dr. Hendifar did discuss very nice studies of the different therapies that we know there is a benefit in neuroendocrine tumors. I think these top 5 will be also my top 5 as well. So I think we're very excited about those treatments, and those are the things that we're very excited that we have now therapies that has proven to be efficacious of neuroendocrine tumors. I'm also wanted to understand about the results of the alpha PRRT. I think everybody's very excited to know about this. And that said, we still don't know when into the treatment algorithm it will fit, in terms of the alpha, whether we do alpha first and then beta, or vice versa, or what will be the sequencing? Do we start right after the other? So I think those are questions that we still don't know the answer to, but that's still an exciting time to see what may happen in the future. The other aspect that I'm seeing as well with talking about PRRT is a combination therapy with PRRT to increase efficacy of PRRT. So that's still some studies ongoing for that. So I would like to, excited to know the results of that. And one thing is about some other therapies, like more how we are able to understand the tumor immune microenvironment in order to make some of these therapies more effective. And I have to say, even at the NIH, we're doing some studies with that. So, and that's something that I will look forward to see what the results are.
Lots going on. Dr. Hendifar, what are you most excited about?
For me personally, I find the molecular classification very interesting. And so I think as the science gets better for these types of tumors, we'll be able to tell a patient, hey, we did a X, Y, and Z test on your tumor. We understand what the underlying biology is, and so we're going to pick this treatment for you. Instead of like what I said before, it's a coin flip or a toss-up sometimes.
Really understanding the tumor and personalizing the treatment. Oh, thank you. Dr. Yu, what about you?
Well, as I've been in the field for quite a long time, I become less excited about new things now, because you see things come and go, and you really wonder how long it will stay. Because we see a lot of supposed to be great things, but then they did not really pan out. But if I can be excited, that will be, I agree with Dr. Hendifar. I think the personalized medicine probably will hold the largest hope. For example, the use of belzutifan, in the past, we treat all pancreatic neuroendocrine tumors the same, right? So they give you everolimus, Sutent, but now, you can do a genetic study of the tumor to see whether a patient has certain mutations or not. If the patient does have it, then you can try to belzutifan. Other things would be in a genetic syndrome called MEN2. It can cause medullary thyroid cancer and pheochromocytoma, but there's a specific a treatment for the oncogene called RAD. So now even if you don't have those specific tumor, but you have a mutation on the RAD oncogene, and you can be fit for the treatment. But again, we have to see whether this will make a real difference or not. This is, again, just on paper. Another thing I'm thinking of that artificial intelligence, not everybody talking about it. Would that be helpful in terms of diagnosing, a tumor early on and tell what it is? For example, you have a pancreatic tumor, so what is it, right? Can we just use a computer to get a better diagnosis so that we know it is a neuroendocrine tumor or is a pancreatic ductal carcinoma, or even a neuroendocrine tumor, is it a high grade, low grade? Can we tell anything from imaging? So I think those things hold a great help, but again, we have to be realistic and keep our mind cool in terms of whether they're going to make a real difference or not.
So really understanding the tumor better and tumor mutations so that we can personalize the treatments. Thank you, all of you, for this excellent discussion. Thank you so much for all your time and effort. I mean, these doctors, they're giving up their Saturday to be with us and really educating us and celebrating that Cancer Day with us. So thank you so much.